Hello friends, I am Dr. Vidyasagar Chandankere, pediatric orthopedic surgeon from Hyderabad, KIMS Sunshine Hospital. So we'll talk today about Perthe's disease and get to know the theoretical aspect of what the PGs must know. So coming to the definition itself, it's a self-limiting developmental disorder which affects the femoral capital epiphysis, which results in a temporary disruption of the blood flow to the head, followed by restoration. And during this period, the head can get deformed. And ultimately, the head shape may not be restored, but the complete revascularization happens. So this is common between 4 to 8 years of age, but there are always outliers. This problem or disease is also known with multiple names like coxa-plana, osteochondritis deformis juvenalis, pseudocoxalgia, Legg-Calvé-Perthes disease, and then Waldenstrom's disease. Coming to a brief history. So initially in 1909, Waldenstrom of Sweden, he confused this condition with an early form of tuberculosis. But again, he later on described it as coxa-plana. That was the first description. And later on, three authors, one is Arthur Thornton Legg from America, and Jacques Schall from France, and George Clemens Perthes, a German surgeon, independently described these three entities. That's why it is named under all these three people, called as Legg-Calvé-Perthes disease. So Paul Sodat, who was also a Carl student, explained the radiographic appearances of these diseased hips, and Schwartz was a pathologist and a colleague of Perthes who provided the first drawn illustration regarding the blood supply of the femoral head. And he also defined it as a self-limiting condition, which is non-inflammatory in nature, which leads to femoral head deformation and then restoration of the shape and supply. So this is a picture which shows the blood supply of the femoral head in a 2-month-old child. So if we see, there are a lot of vessels which are going from superior, a lot of vessels from inferior, as well as from the metaphysis. So early stage, when the physis is not present, there is a free flow of blood vessels or blood supply from the metaphysis to the capital femoral epiphysis. But once the child is around 4, that physis, that is the femoral head physis, acts as a barrier, and then it may cut off the blood supply which comes from the metaphysis. So the only sole supply to the superior and the lateral part of the femoral head comes from the lateral retinacular vessels, which are seen here, and a minimal supply from the medial side. So this is a 60-year-old person's X-ray with the fine angiography done. So we can see here again the vessels are there, which is from the ligamentum teres as well, and from the metaphysis area, as well as from the superior. So there the risk is again less. Why I wanted to show the slide is this period of 4 to 8 years is a peculiar period where the blood supply is solely dependent on the lateral retinacular vessels, which is the main blood supply to the femoral epiphysis. And there is no much supply from the ligamentum teres as well as from the metaphyseal area. So coming to etiology, why this Perthes we see commonly in this age group, there are many supposed factors which say that these could be the reasons why the Perthes happens. Some of them are trauma, nutritional deficiency, and then thrombophilia, where there is a tendency to hypercoagulate. And then it's commonly seen in attention deficit hyperactivity children who are more prone for trauma, of course. And there are environmental factors, because these are seen commonly in the coastal belt, in especially South India, the western coast. Smoking exposure is said to be a factor leading to Perthes, and there are other hormonal factors, and delayed skeletal maturity is also noted in some of the children. So there have been hypotheses proposed as to why this happens. So the Trueta hypothesis is based on mainly the vascular theory. There is a disruption of the blood supply for some reason, and that leads to the femoral head deformation. And that's why they say that it is common between 4 to 8 years, because the supply is very reserved, or the sole supply would be the lateral retinacular vessel. And then there is a Caffey's theory, which proposes that there is a compression of the femoral head, and that leads to vascular compression. And it also suggests that micro trauma event could lead to this vascular compression and synovitis in the joint, which can also cause the vascular compression. And some propose that there is a venous drainage problem here, which is disturbed, and that's why this thing happens. So there is nothing which we can prove, but these are just hypotheses. But that's why I like this unifying hypothesis. That is, there is a thrombophilia happening, and there is also congestion and synovial thickening and synovial inflammation, which leads to these changes. And there is micro trauma, of course, which all the factors combined can lead to the problem. Coming to epidemiology, it is common in South India, as I already mentioned, in the western coast area, and males are predominant. That means males are more affected than the girls. The ratio is usually around 4 to 5:1, and the common age group is 4 to 8 years, but there are outliers. Some children can present as early as 2 years, and there are late presenters at about 11 or 12 years, which we call as late Perthe disease, and it behaves entirely differently. So bilateral cases can be seen in about 10 to 15% of cases, and usually when we see bilateral cases, they are asymmetric. That means one hip is affected earlier than the other hip. Hereditary reason is also suggested, and children with HLA are prone to this problem, and it is also more common in children with short stature. And coming to pathanatomy, so there is a pathanatomy. There are some changes on the femoral side, and there are also some changes on the acetabular side. What do we see in the femoral side? We see the synovial effusion in the joint and a hypertrophic head cartilage, which leads to subluxation later on. We see hypertrophic ligamentum teres, and then coxa breva, the head deformation, and sometimes GT overgrowth at the end of the healing. So why does this happen? Basically, we'll talk about in the next slides, where I'll show some pictures. And on the acetabular side, we see the cartilage hypertrophy. The acetabulum may become bicompartmentalized. That means instead of one, it becomes two compartment, and there could be mild steep acetabulum, which is called as dysplasia, and sometimes we see retroversion. So coming to the physiology, it has been noted that there are 4 stages, which we'll talk about in the later on when we discuss about the radiology also. Initial stage is avascular stage, and where the femoral head blood supply completely stops, and the second stage is the fragmentation stage, where the blood supply regains, but there is a imbalance between bone formation and bone resorption. And then there is a third stage where the bone formation is more, and then head starts reossifying. And then there is a last stage where the head is fully ossified, but it tends to remodel according to the shape of the acetabulum. So I'll skip this theory, and I'll just show you the slides of this. So this is the pathanatomy. So what we see is basically it's important to know that the femoral head is affected. So when we see the femoral head ossific nucleus, it is in the center. It's smaller than what we see in X-rays, and there is a lot of cartilage in the femoral head, which is unseen in plain X-rays. So what happens basically is there is a complete cessation of the endochondral ossification in the femoral head, and then the cartilage thickness increases because the synovial fluid is good and it nourishes the articular cartilage. The cartilage actually hypertrophies, and that itself sometimes leads to hypertrophic ligamentum teres, and hypertrophic cartilage leads to subluxation or lateral extrusion, we call, of the femoral head. And upon that, there is because of the irritation, synovial irritation, there is contraction and spasm of adductors and the psoas muscle, which can lead to clinical deformity and further extrusion. So initial stage is that, and when it revascularizes, what happens is slowly the old necrotic bone from the femoral head below the cartilage starts getting reabsorbed. So this is the stage when we see the fracture line, or what we call the crescent subchondral fracture. So That's the line which we see in this stage. And once the bone is resolved, it is also again followed up by bone formation, and that again leads to restoration of the bony nucleus. So during this period where the bone is being actively resorbed and actively formed, there is a high risk of femoral head deformation. And that's the whole theory on which the treatment of Perthes is based on, because we don't want to get a deformed head at the end of the healing. So idea of treatment or whatever we do in Perthes would be to restore the femoral head shape at the end of healing to a very congruent and concentric reduced femoral head. So then the last stage where we see the bone formation is more, and generally when we see osteoclast and osteoblast activity, the osteoclast activity is always more. That means what they do in 3 days, the same thing osteoblasts take about 3 to 4 weeks to form the same bone. So when there is an imbalance, naturally the osteoclasts are going to win. So that's why in the early period the head is soft and it is susceptible, and based on that only there is a principle of what we call as Salter's principle of biological plasticity, where if the femoral head during the periods of deformation or softening, if it is kept deep inside the acetabulum, it takes the shape of the acetabulum and comes out rounder and more spherical, and based on that principle only the treatment of Perthes will be there. So that's the fragmentation stage, and the findings I think you can read up. I'm not going to talk about that. So this is the MRI films of the same Perthes child on the left hand side. On the right hand side, that's a normal hip. In the first slide, if we see, there is the head changes on the left side. It's quite dark and less intense. On the other side, it's the normal well perfused head, and that's the changes of avian. In the second one, coming to the down middle one, you see the hypertrophic ligamentum teres marked as $sign, and on the other hip it is not hypertrophic. And coming to down, it shows the thickness of the triradiate cartilage, where it is markedly thick here and less there. So coming to the pathophysiology, what I already described. So what are the things which are going on in the hip in Perthes disease? So there is ischemia of the femoral head, and there are mechanical forces. That means the child is weight bearing all the time on that ischemic head, and inside the hip joint there is inflammation going on. With that inflammation, there is resorption and bone formation. Both the things are going on simultaneously in the second stage. So what happens generally when both the things happen, the resorption wins, because it takes a shorter period of time for the osteoclast to clear the same bone than the osteoblasts can lay down. So that's the first figure which shows the avascular segment in the femoral head, and as the articular cartilage hypertrophies, the medial space keeps on increasing, as I am showing here, and then as the space increases, the head starts extruding out, and whenever the head starts extruding more than 19 or 20%, we call it as lateral subluxation or extrusion of the femoral head, which is again a classic indication for further aggressive treatment. And upon that, lastly, we see that there are weight bearing forces. Even in non-weight bearing forces, the muscle spasm of the adductor and psoas is enough to deform the femoral head. So that's the avian pathology which is going on, and this is the disease process which leads to resorption, trabecular collapse, cartilage hypertrophy, and then secondary extrusion. And that's a repair process which is going on simultaneously, which is irregularly woven bone is laid down, and then there is a weight bearing stress on this irregularly woven bone. That's why the head collapses, because here the bone is soft when the bone is resorbed, and when the new bone is laid down, it is not hard or as strong as the bone which will be there in remodeling phase. So that's why it undergoes deformation under the forces, and because of this only the head deformation starts. So I'll show you a very interesting chart here, which shows the femoral head mechanical strength in Perthes disease and in a normal side. The normal side is depicted in the green and the Perthes disease in the red. So if we take the time, as the time progresses, initially at the onset of disease, when the head is avascular, the strength of the femoral head is very good. But as the disease progresses slowly, the head becomes weaker and weaker, and this is the fragmentation stage during which the head is highest risk, and then the bone reformation starts, and this is the healing and the remodeling stage. So please remember this slide, and it helps you even in exams. So this is an example of a child followed up serially over a long period of time, and he didn't take any treatment, but we have the x-rays to show you. From 5 to 8 years we have followed with the child. If you see the x-rays, serial x-rays, the head started fragmenting, and only in early fragmentation stage, if you see, the again head started extruding outside and collapsing. And this is the stage which we have marked in red, which is important, which is the fragmentation stage or the early ossification stage, when the head is susceptible for extrusion. So that's why this stage is always emphasized on when we are managing Perthe's hip. And lastly, that is the heel stage, and then it will remodel slowly, leading to a ovoid head. So when it is called extrusion, when the femoral head, so if we calculate the width of the epiphysis, that is from the lateral border to the medial side, and that width divided by whatever part is outside the lateral edge of the acetabulum, that A by B into 100 gives you the extrusion index, and normally more than 20% is called as extrusion. So that's why we do follow up them serially, so that if we see anything like a progressive extrusion or extrusion more than 20%, then we will be more aggressive in our treatment. So this is again a slide to show that deformation and extrusion both are related. So that means once the head start extruding, only the deformation happens. So if we see the stages, the down, we have shown the modified Elizabeth-Town staging, and in the vertical alignment it is the extrusion of the femoral head. So if we see from around 12% extrusion, when the stage comes to around 2B, and then the head becomes irreversibly extruded and deformed. So whenever the extrusion index exceeds 20%, there is irreversible deformation of the femoral head. That's what the slide means. And we do see metaphyseal changes as well. Most of the changes are reactionary changes. That means because of the event which happens in the femoral head, the surrounding structures like acetabulum and even the metaphysis gets affected. That's why you see the metaphyseal cysts, sclerosis, widening of the neck, and even shortening because of the growth related problem. So what do we see clinically? We see a child, initially the child may present with painful limb, and slowly the limb becomes painless, and you may see minimal shortening with a painless limb in later stages. And you may notice a Trendelenburg gait, that is a lurch, and the shortening is generally minimal. What are the signs? In the early stage, we see a child having signs of synovitis or anything like a observation hip. So child will come with a limping gait, and on examination there will be low limb length discrepancy, but you may see some flexion and limitation of abduction and internal rotation, something like a irritable hip. But clinically the hip range of motion should be good, and maybe terminal limitation will be there. As the synovitis stage passes on and then it goes to further advanced stages, you may see a painless limb in the child and limitation of abduction and internal rotation. And clinically you would be able to elicit a Trendelenburg test, and the minimal shortening will be there, up to 1 and 1.5 centimeter shortening will be there at this stage. And generally again stages are ischemic stage, fragmentation stage, reossification, and a heel stage. So when it comes to the classification, the Salter classification applies to the ischemic stage, and the Herring and Catterall classification applies to the fragmentation stage, and the outcome, that is Moses and Stulberg classification, applies to the heel stage. That means when the femoral head is fully ossified. So once it is ossified, it won't help us in the treatment. During the active phase only, either in ischemic stage or fragmentation stage only, our treatment line can change. So that's why those classifications are more important. The Moses and Stulberg classification are indicators of the long-term outcome. That is, once the femoral head has completely healed, whether it will go for a early onset osteoarthritis of the hip, or it will be a normal hip, or it may not show any changes until very long time, will be dictated by the final outcome at the healed stage. But our initial treatment will depend on the other stages which we mentioned here. So this is a serial X-rays of the child who had Perthes disease. So initially, if we see the X-rays, there is a slight rarefaction of the femoral head in the figure A, and in the B we can see that there is a slight collapse or flattening of the femoral head, and in C you see that there are two radiolucent lines which are dipping into the femoral head till the physis. So that those are the fragmentation lines. They are indication of fragmentation of the femoral head. In the D, the lines is more, which is the late fragmentation stage, and then slowly the ossification starts, which is E and F. That means the ossification starts always laterally and then proceeds medially. And then when you see the F slide, the head is almost ossified except a little bit in the center, and G is a fully remodeled stage. So these stages all the hips will undergo, unless there are some hips which you intervene where it skips the fragmentation stage. So this is the avian stage, this is the fragmentation stage, that is the reossification stage, and then last is the remodeling. So there are some signs in the femoral head which we see, which we call as head at risk signs, and these 5 signs you should remember, because examiners would like to ask these questions. But the first sign would be the gauge V sign, that is radiolucent lateral V shape this thing, which I will try to show you here. That is a gauge V sign. And then the horizontal physis, if you compare to the normal femoral head, the physis has become horizontal. And then there are metaphyseal cysts, if you see, cysts have developed. So that's one more. And lateral calcification, that is here you can see lateral calcification, just lateral to the femoral head epiphysis. And then extrusion of the femoral head. If you see, the head is already outside, so that's the extrusion. The most important criteria here among all the head at risk sign which will dictate or change your treatment would be extrusion, because that can be recognized and you can do something about it. So this is a 5-year-old child who has been followed up. So what I am mentioning here is the gauge sign. You can see here, that's the lateral translucent V shape. And then slowly the head height has reduced, if you see. And then there is a lateral ossification which is happening. And with that, if you see, the femoral head has subluxed, it has come outside. And you see the medial gap that's widened. And slowly the head starts ossifying. This is the reossification stage. And then slowly, once the ossification is complete, it will start remodeling after this stage. So that's the extrusion. So coming to investigations, the basic investigations involve only X-rays of the pelvis, AP and lateral, and these have been mentioned for just description's sake, but otherwise you need only frog leg view and a true AP view of the pelvis to see what's happening. The AP view shows you what are the changes you see in the femoral head, epiphysis, metaphysis, and lateral view also shows which is affected more. Remember, in Perthes, the anterior superior or anterolateral part is affected, and that's why you see in lateral view, frog leg view also, the anterior part affected or collapsed, and in AP view you see that the lateral collapse is there. The other investigations are there. Among that, the most helpful one would be arthrography, because it can show you all the changes along with the cartilage of the femoral head. That means how much of the head is there truly in size, whether it's a coxa magna, it can show you, because the head itself is ossified less, but there is a lot of thickened cartilage around the head. And it can also show you how much of the head is contained actually in the acetabulum, because in children, whole of the acetabulum and the labrum is not yet ossified. So you might not know the true coverage of the femoral head unless you do an arthrogram. And it also helps you in defining the best position of the congruency. That means if you are going to do an osteotomy, whether a valgus or varus osteotomy, it determines in the which position of the hip the acetabulum and the femoral head are getting most congruent. and that's how after X-rays that would be the most useful investigation. Sometimes an MRI helps in early detection when the X-rays are normal, when the stage is still in avascular stages, and MRI can also throw more light on the amount or the segment of the head which is affected, whether the whole of the head is affected or partially affected, it can tell you. But we don't do routinely the MRIs and other scans. And CT scan, yes, it can be helpful in the later stages, like when it comes to a healed stage where you are planning for another procedure where a 3D deformity of the head needs to be described. At that time, CT scan is very helpful, but otherwise we don't get any of these except X-ray and arthrogram are the commonly routinely used things. So coming to differential diagnosis, what else could look like Perthes? So a chronic infection in the femoral head, like tuberculosis, can, because there is a Perthes type of tuberculosis which is mentioned, and the avascular necrosis itself, like in sickle cell anemia and steroid induced, they can look like Perthes. And then there are various skeletal dysplasias where the femoral head is affected, including mucopolysaccharidosis and all those syndromes, where the head may be flat and fragmented. And even in hypothyroidism, you see these changes. Rarely you can see these changes in tumors, and sometimes osteochondritis dissecans of the femoral head can also look like Perthes. So you must keep this in mind. That's why the history is important. A good brief history followed by clinical examination, and then radiographic examination can rule out most of the things. Coming to X-rays. So this is a hip joint X-ray in a normal child. So AP view, and we can see that's the teardrop here, and this is whole of the acetabulum. We can see this is the gap medially. This is the femoral head, and this is the physis, and that's the metaphysis, and this is the GT. And this is a child's X-ray in Perthes disease, probably in the reossification or late fragmentation stage. And what changes you see here, you see this medial widened joint space. You see obviously the femoral head height has reduced and it is flattened. And then what else you see here is a lateral ossification which is beginning to happen. You see some metaphyseal reactionary cysts. You see widening of the neck as well as of the head. And GT overriding or GT overgrowth will come later on. Once the remodeling happens, the femoral head, the physis doesn't grow as well. So then the GT physis grows normally. That's why you see there is a trochanteric overgrowth in late presentation cases. And if you see here, no, this is the edge of the acetabulum where I'll draw this what we call as a P or Perkins line. So this is the amount of extrusion which we are seeing. So MRI, as I told, it's not routinely done, but it can indicate in the early stage where the X-rays are normal, and it can indicate also how much of the femoral head is affected. But you know, there are again disadvantages, like the cost is high, the child needs to be sedated or anesthesia needs to be given because they are usually uncooperative. And in some cases in the peripheries, it may not be available. But this is not the one which will dictate your treatment. Scintigraphy is again rarely used, mentioned for just know what it can show, a low uptake, and later on it can revascular and show a normal uptake. Arthrography is definitely useful. See, I want to demonstrate here beautifully what is happening. So if you see in the topmost figure, the femoral head is almost like a wafer thin epiphysis. But we think that the head is so much only. But if you do the arthrogram of the same child, the head is actually so big. That's the size of the femoral head. And if you see now, I'm going to show you the congruency what I talked about. So this is the acetabular joint surface, and this is the femoral head joint surface. So this is extremely congruent. That means they are parallel and running along with each other. So that's a good ultimate thing which we want when we are trying to discuss about the management. And this is the extrusion actually I'm talking about. This is some amount of femoral head is outside. So orthography can help us truly in deciding a good containment and whether there is a hinged abduction, and it can also show you which position of the head would be preferable after osteotomies, especially when we are doing valgus osteotomy. Ultrasonography not routinely done, so it's just for mentioning, saying that that is here. And again, CT scan, as I said, it is mostly helpful in the healed stages where we are going to do a 3D correction or head reduction osteotomy. It might be helpful. Coming to radiological classification, one is based on the chronology. That means all the patients of Perthe will pass through all these 4 stages. That is stage of avian, stage of fragmentation, stage of healing, and then remodeling, which is described beautifully by Waldenstrom. And then actually coming to classification, that is a staging. And when we come to classification, it is based on the severity of the head involvement. So there are 3 classifications, and based on how they are mentioned, or which was the earliest was Cattrall, and then Salter Thompson, and then lastly Herring lateral pillar classification. And then when it comes to outcome of the disease, that means when we see in the remodeled stage, there is Mosaic classification and Stulberg and Sund, which is mentioned. Most commonly we use the Stulberg and Mosaic to dictate the natural history or predict the natural history. So coming to Waldenstrom's classification, we all know initial stage is stage of avian, and then fragmentation, reossification, healed. The initial stage lasts for 6 months to 12, and then fragmentation could last from 6 months to 1 year, and then ossification lasts for a longer period, that is 3 to 5, and healing takes usually again same amount of time. And I have mentioned these changes in the X-rays before also. So initially what we see is slowly the femoral head density is increased because it is avascular. It becomes kind of a sequestrum and there is no blood supply. So there is no much bone resorption and happening. So that's why it becomes more sclerotic initially, and then slowly with time you could see a subchondral fracture line, which is also called as a crescent sign or crescent line, which is the basis of classification for Salter Thompson, and that's the widening of the medial joint line. This is 6 mm here, and the other side, if you see, it is quite wide, that is around 10 mm. And if you see here, the head size is more and the head epiphysis size is less. And when you see laterally, this is the collapse which you are seeing, and this is the lateral pillar height which is reduced, and there is mild acetabular dysplasia as well. So what is Waldenstrom's sign? That is lateral displacement of the femoral head by 2 mm to 5 mm, which results in the joint widening of the medial side, which I showed, and that's called as Waldenstrom's sign. And this is the Caffey's crescent sign, that is subchondral fracture line, which I am showing here. So it's important to remember that you may not see always this line. It is seen only in about 20 to 25% of the cases. Other cases you don't get this. And this is the earlier to probably fragmentation stage. You see this. That is the late avian stage. We see this line. And then comes the fragmentation stage, where the collapse of the femoral head starts happening. And that's the fragmentation of the head which we are seeing. And by fragmentation, it means that simply instead of epiphysis being a hole like this, it appears as if it is broken into different pieces, and that's the fissure lines what we see. And when the reossification happens, usually it happens in the lateral part of the head, and this is almost a reossified head. That means it is in the late reossification stage, and healed phase is when the head is fully ossified. So this is the healed stage, and here you can apply the classification as proposed by Moses and Stulberg and Sund. So Apley's sagging rope sign is also a sign of residual, where the head kind of overhangs and appears as if it is in the metaphysis. So it is nothing but deformed head which hangs down, and that's what gives the name of Apley's sagging rope sign. And we know that the acetabular changes also happen even though the head is avian, because these are all reactionary changes, what we call. And it leads to bicompartmentalization of the triradiate cartilage, and sometimes the acetabulum becomes more steep and dysplastic, and there is also premature fusion of the triradiate cartilage. So, it gets fused very early. So, these are the three changes which we see in the acetabulum side, and you should keep a note or make a note of it. So, what can we see in the femoral head? We see coxa magna, that is a big head. We see coxa breva, that means not a small head but a short neck, and then we see coxa vara, that is a reduced neck shaft angle, and we see sometimes hinged abduction, that means the femoral head, instead of abducting at the hip, that is the center of the hip, it starts abducting at the lateral edge of the acetabulum because of the misshapen femoral head, that is collapse, and I will talk about it later on in my coming slides. And there is also trochanteric overgrowth. So, based on the extent of involvement, that is the severity of involvement, these three classifications have been proposed. The earliest was Cattrall, and we will talk about that. Cattrall classification has 4, that is group 1, 2, 3 and 4, and usually this is applied in fragmentation stage only. It cannot be applied in the early avascular stage or later on. Group 1 is where less than 25% of the femoral head is involved, and in group 2 where 25 to 50% of the head is involved, and you see metaphyseal cyst as shown in the slides here. And 3 is slightly more severe, where whole of the head, that is almost 75% of the femoral head is involved except a residual bit here, and then you see other changes like cyst and all, and last where whole of the head is again fully involved, that is the stage 4. So, the problem with this classification is, one is there is most of the times confusion between group 2 and 3. So, the inter-observer reliability is very less in this, and then this applies only to the fragmentation stage and cannot be applied early on, so that we can decide what treatment or how aggressive our treatment should be. So, this is the group 1 where head is involved less than 25%, then 25 to 50%, then we see 75% involvement, and this is the entire head is involved. So, I have already talked about, and I already figured, and I have already spoken about the disadvantages as well. So, coming to Salter-Thompson classification, which was proposed later on, it has only 2 types based on the crescent sign, that is the calf is subchondral fracture line. If the fracture line is less than 50%, it is group A and generally supposed to have good prognosis, and if it is more than 50%, it is group B and it is supposed to have a poor prognosis. And what is important here is this cannot be applied in all the cases, even though this is the classification or radiological classification which can be applied very early on in the staging. That means right at the avascular necrosis stage we can apply this classification, but this fracture line is seen only in about 25 or less than 25% cases. That is why it cannot be applied for all the cases, because it is not seen, and that is the limitation of this. But the advantage is, yes, it can be applied very early, and whether you want to treat it aggressively or less aggressively can be decided based on this, and it is present only transiently. So, that is the subchondral fracture line. Coming to Herring classification. So, what do we mean by lateral pillar? We talk so much about lateral pillar. What is the lateral pillar? So, I am going to tell you here. So, this is the femoral head which you are seeing from here to here, that is the femoral epiphysis. So, if you take the whole of the width of the epiphysis and divide it into 3 equal parts, then you get a medial part, you get a central part, and you get a lateral part. So, this is the part which we are talking about. So, this is exactly lateral pillar height which I am talking about. So, based on the height of the lateral pillar, why the lateral pillar is important? Because that is the most weight bearing part, and that is the part which is going to get affected highest and deformed also. So, that is why the lateral pillar classification is significant, because that will determine ultimately how your femoral head is going to extrude or deform. When you have the height which is good height, completely retained height, that is group A, and when you have a group B where the height is from 50 to 100%. That is, it is reduced to less than 100, but more than 50 height is still retained, and there could be some evidence of extrusion. And this is group C, where it is reduced less than 50%, and generally these have poor prognosis. And there is another group which is described as BC, that means where the height of the pillar is up to 50% maintained, but there is a narrow physis laterally. That means the ossified area is narrow, very small and tall. So that's the A, where the height is fully maintained, and that's lateral pillar group B, where height is reduced less than 50%. And then if you see, the height is maintained, but again the width and this is reduced. And if you see group C, the whole of the femoral head is unossified, or most of the head is affected and it is collapsed. So coming to this changes here, this is the central sequestrum, which we call, that's the head, which is sequestrum, and this is the gauge sign which I wanted to talk about. And then you see the metaphyseal cyst here, collapse of the head, widening of the medial space, and then lateral ossification. So natural history of the disease. So now Perthes can lead to almost a variety of outcomes. If the children have Perthes early on, that is when they are young, it can lead to a normal hip and full reossification with a spherical head and a spherical acetabulum. And in other cases, it may have sometimes ovoid shape of femoral head. It can lead to early onset of osteoarthritis at around 50. And in severe cases where the head is mushroom shape, or the femoral head is flat and the acetabulum is round, it can have a early onset arthritis even in the early 40s. So these are the natural histories which can happen. Everything is based on the age of presentation and what is the severity of the problem. So this is the natural course of the disease, which we have already described: avian stage, then fragmentation, then reossification and healing. So that's the modified Elizabeth-Town classification. That means the Waldenstrom classification was only modified, that is type 1A and type 1B. 1A, there is no reduction of the femoral head, but you can see there is sclerosis of the femoral head. 1B, you can see mild reduction of the femoral head, but there is no fragmentation which has still appeared. That is avian stage. When it goes to fragmentation, it goes to 2A. That means you see two fissure lines or less, and you can see two fissure line and less there, and head starts fragmenting. Then you see 2B, where there is more than two fissure line and further fragmentation, and then head starts reossifying. 3A, early reossification, which happens initially laterally and less than 25% is ossified, and then goes on to more than half of the head ossification, and later on healed stage. So this classification is routinely used by us for treating or for management, because this identifies correctly at which stage the head is prone for deformation and when you can prevent by a proactive action, whether it's conservative or surgical, doesn't matter, but when you should intervene, it can tell you. So we have discussed already about the differential diagnosis, so I'll skip this. And so prognostic factors, these are the factors which we'll again discuss in coming slides. So this is a metaphyseal cyst, collapse of the femoral head. It's a type C herring lateral pillar. If you see Catrol, it is almost grade 4, and Salter-Thompson can't be applied here because it is almost in the fragmentation stage, and it is also a wafer epiphysis if you see. So these are the prognostic factors which I'll talk about. Age, early age, good prognosis; late age at onset, poor prognosis. Gender, males usually do well, females don't do so well. Then extent of physeal involvement, that is, if the physeal head is involved more, then severe problem; less, that means less than 25% or so, good prognosis. Collapse, once the head collapses, that is lateral pillar, type C, poor prognosis. A and B herring, very good prognosis. And then when it comes to mesophyseal abnormalities, which we see as a cyst and all, they are head at risk signs. So that means severe involvement. And when you see even acetabular changes, it means severe involvement. And another important clinical and radiological finding would be a femoral head extrusion, which we see in X-rays. And this is a important sign. That means once the head extrudes, it's going to deform, as we saw in the previous slides. So that's the one it can alter the, because other things we can't control, but extrusion, yes, we can control. That's why I told it's a most important factor. And that's the reason once the head start extruding, we recommend containment.